Hi dear doctors, welcome to the class of Kidscovery. I am your pediatric faculty. My name is Dr. Parv Luthra. We are discussing about the broader domain of pediatric nephrology, and the topic of discussion is approach to proteinuria in children. So the normal value of protein excretion is less than 100 mg per meter square per day if it's a children, and if in neonates it's up to 300 mg per meter square per day. These are the normal values. Okay, so just to remember, 300 THREE, 3 knee neonates. Okay, 3 knee for neonates. Coming on to the mechanisms, so understand there are two mechanisms which operate. One is called as glomerular proteinuria and tubular proteinuria. Now, what is the meaning of glomerular proteinuria? That means, see, the glomerulus is responsible for the filtration. If there's a lot of filtration which is going to happen, that means of course in the urine there is going to be a lot of protein which is going to come. Another is called as tubular proteinuria. That means, see, in tubules there occurs reabsorption. So if it is decrease in reabsorption, that is going to come in the urine. So that's called as tubular proteinuria. Now again we have got some hints and then we will discuss about the causes. So if the patient gives you, or the laboratory findings hints you, that there is a transient proteinuria, that might occur normally also, like with the hypovolemia, with the exercise, with fever, with seizures. Okay, in all these conditions, in exercise there is a lot of protein breakdown which is going to occur, so that protein is going to come inside your urine only. Okay, so what you have to do in transient proteinuria, we have to repeat the test later once the fever resolves, the seizures resolves, and usually we have seen that it is spontaneously resolving. Okay, similarly in hypovolemia also, the water content is less, so of course the protein is going to be relatively higher. Coming on to persistent proteinuria, that means if it is persistent, then it can indicate glomerular diseases, and in the children the most common glomerular disease is nothing but MCD. What is MCD? MCD means minimal change disease. Okay, MCD means minimal change disease. So minimal change disease is something which is going to show you the persistent proteinuria. And of course IgA nephropathy also, M and A, these are important. And when it comes to your tubular diseases, you can have polycystic kidney disease, Wilson's disease, as well as cystinosis. Okay, so C, polycystic kidney disease. Okay, this is also a cystic disease. Okay, polycystic kidney disease, C for cystinosis, and W for Wilson's. So MAC, and you very well know that M looks very similar to W. So WMAC is the mnemonic to remember these causes of persistent proteinuria. So you can remember, we as children always used to do a persistent request to our parents to kindly give us MacBook, right? So of course if febrile or exercise history, it's transient only. Okay, and then the good part is that if it's a febrile or exercise history which is going to happen, in this case you have to understand that you have to check for urine changes, of course, if for edema also, because edema is something which is associated with nephrotic syndrome. Okay, nephrotic. We also going to have a check on the strep infections, because strep infections are also the risk factors for IgA nephropathy as well as for PSGN also. If the patient is afebrile and there is a trace proteinuria, we have to just repeat the first morning urine sample, and if still the trace amounts are present, we have to continue the observation. And if it's afebrile and +1 proteinuria is going to be there, again you have to do the same, but this time you are supposed to check the protein-creatinine ratio also, because protein-creatinine ratio is going to tell you about the pathology of the kidney. Okay, so if it's a tubular disease or if it's a glomerular disease, that is going to be cleared out by this protein-creatinine ratio. If the morning protein-creatinine ratio, now understand this, if the morning protein-creatinine ratio is less than 0.2, that means it's a benign disease. We have to just repeat the dipstick. If it is more than 0.2, it needs further evaluation. Check the BP, blood urea nitrogen to the creatinine, electrolytes, albumin, C3, C4, ANA, hepatitis B, C, renal USG. Actually, why we are checking all these things, when you'll discuss the nephrology in pediatrics, you'll be very well able to understand. But as of now, my work is just to tell you like what you are supposed to do as the next step. And very simple things. If now the evaluation, after the evaluation, if evaluation becomes normal, just repeat the dipstick in 2 more separate samples. So this is just something which you have to keep it in mind, because this is something which you can write in every kidney disease. You can write proteinuria and you can write these things, okay, there. So thank you so much for watching and attending this small little lecture, which is actually a big important topic when it comes to your kidney disease. Thank you.